Immunotherapy these days are mainly focus about so-called PD-1 or PD-L1 therapy, but the CAR T-cell therapy is most of fashion, and we also that in hematological disease we have very exciting efficacy, but in solid tumor is just struggling for extra efficacy or some safety profile. So you mentioned that our presentation is about our EpCAM target. So just as your first question for why we select EpCAM as our target. EpCAM so-called epithelial cell adhesion molecule, so-called EpCAM. And we also can say it is CD326. It's a transmembrane glycoprotein. So EpCAM is familiar to us, and why we select it to our target, to our first in human cell therapy, because you know that it's expression. Although it's also expression in normal tissue. For example, we saw that gastrointestinal and biliary duct and also thyroid. But we also know that it's low expression, and you know that just as I have mentioned in my mini-oral, because the expression is lower in normal cell, and it's lying in the basal side of the epithelial cell. So in normal situations, the immune cell cannot contact the molecule directly. So on the contrary, we saw that in the colorectal, on the gastric, on pancreatic, on ovarian, and the breast, the cancer of that tissue will higher express the EpCAM molecule. So we can select this target as our promising target. And also EpCAM can act as a signal transmitter to activate so-called WNT signal pathway. We all know that the WNT pathway is tightly related to the tumorosis and the progression of the tumor. So we think that our selection may be a promising tumor TAA. So we can use this target as our CAR T selection. So we think maybe this first in human trial, this first in human cell product will be a good selection for us. Of course, we will do more trial in human to clarify if whether it is a true and a very good target for the human cancer therapy.